There is itching, sore throat, no nasal congestion, sore throat, but maybe like young boy with cervical lymph node, or maybe lymphoma, leukemia, this type of thing, fatigue. What is your because oh, but he has most they are talking about most appropriate, but he has fever, so maybe excisional. So this patient, okay. So these patients, these young patients, subacute fever, pruritus, fatigue, and painless cervical and supraclavicular lymphadenopathy raise strong suspicion for Hodgkin lymphoma. Cases generally arise in bimodal distribution with peak incidence in 15 to 35 and more than 60. Hodgkin lymphoma typically arise in single Hodgkin lymphoma typically arise in single lymph node and disseminates to contiguous nodes via lymphatic and thoracic ducts. Patients generally present with painless peripheral lymphadenopathy. Painless peripheral lymphadenopathy, particularly in the cervical and supraclavicular chain. Significant mediastinal lymphadenopathy also occurs in 50% of the case, may lead to cough, shortness of breath, chest pain. Most patients have long-standing B symptoms: fever, night sweat, weight loss, and pruritus, a paraneoplastic process classically associated with Hodgkin lymphoma and likely due to cytokine and interleukin release. Individuals with unexplained lymphadenopathy and a finding concerning for malignancy supraclavicular lymph node require excisional lymph node biopsy. Malignant Ritt-Steinberg cell admixed with neoplastic inflammatory cells are diagnostic of Hodgkin lymphoma. Weight, extremity pain, swelling, IV drug abuser. Lymphogranuloma varium is an STD, may not be, it is not STD, isn't it? It may be due to IV drug abuser trauma and a unilateral, is it lymph injection mark, not lymphatic filariasis, lymphogranuloma. Either it is acute lymphangitis or DVT. May not be necrotizing myositis. So, Y- Yes, maybe. Not, isn't it? IV drug abuser. Sorry, trauma. Yes, yes. And the what lymph gland maybe, lymph nodes maybe. So you were thinking lymphogranuloma venerum for DVT to happen. You are right. I am wrong. No, no. Lymphangitis I ruled out. I think necrotising. Yes, it's DVD. It's clear. This patient with a history of injection drug use. This patient with an history of injection drug use and has right leg edema, erythema, and warmth. Along these symptoms often occur in localized manner in injection drug user due to skin and soft tissue infection. The presence of symptoms in the entire leg, an increased thigh and calf diameters, and injection marks in the groin raises strong suspicion for acute iliofemoral DVT. Common risk factor for DVT include prolonged immobility or hospitalization, recent major surgery, obesity, malignancy, oral contraceptive, hormone replacement use, and pregnancy. However, patient with patient who inject drugs into the femoral vein are also at a high risk of DVT due to iliofemoral venous wall trauma, chemical irritation, or infection. Manifestation of the lower extremity DVT includes unilateral leg swelling, pain, warmth. Physical examination often reveals dilated superficial veins and increased diameter of the calf and thigh when compared to the unaffected leg. Initial evaluation typically includes D-dimer and a lower extremity Doppler ultrasound examination. Okay. Uh, Acute lymphangitis is a common complication of the injection drug use due to inoculation of the skin flora into the subcutaneous tissue. However, this condition is generally marked by tender red streaks up the lymphatic channel with painful swollen erythematous regional lymphadenitis. The presence of diffuse right leg symptoms and increased calf and thigh diameter enlargement makes the DVT far more likely. And lymphogranuloma venerum is a tropical and subtropical disease caused by serovirus of Chlamydia trachomatis and is not marked by genital ulcer and inguinal lymphadenitis. And it's not my wrong answer. Necrotizing myositis. It's a rare condition, generally marked by severe systemic toxicity, high fever, hypotension, toxic appearance. There may be discoloration and the gangrene. These patients' normal vital sign and slow onset symptoms make these high unlikely. Okay. There is splenomegaly. So splenomegaly means splenic sequestration. Splenic sequestration reticulocyte count is high and platelet is low, platelet is trapped, or both are high. Why? Platelet is trapped in the spleen, so platelet is dying down, isn't it? Okay. And aplastic crisis, there is decrease reticulocyte count and decrease platelet. Like A. Okay. Okay, I haven't seen your answer truly. I have just eaten. That's why my brain is not working. My brain's glucose is towards the stomach. Okay. This patient with sickle cell disease has markedly enlarged spleen and signs of shock, tachycardia, hypotension, findings consistent with splenic sequestration crisis, and or red blood cell pooling in the spleen. Spleen sequestration is a common complication of sickle cell disease in a younger patient whose spleen have not yet become fibrotic from recurrent vaso-occlusion and infarction autosplenectomy. Red blood cell sequestration in the spleen leads to severe acute anemia and splenic engorgement, resulting in clinical findings of pallor, flow murmur, left upper quadrant pain, and splenomegaly. If untreated, splenic sequestration can progress to hypovolemic shock as a significant portion of total blood volume is trapped in the spleen. Classic lab findings include severe normocytic anemia, compensatory reticulocytosis, and thrombocytopenia. As platelets are also trapped in the spleen. Treatment includes correction of the hypovolemia with isotonic fluid and small volume transfusion and eventual splenectomy. Maybe he has two miscarriage. So two miscarriage at 8, 12, and 16 weeks. Uh, Only two. So looks like antiphospholipid antibody syndrome along with SLE. And APAS has multiple association. Sorry. Yes, it can. Just remember. Wait. Do you remember the box of the antiphospholipid antibody syndrome. Sorry. There may be arterial thrombosis, there may be venous thrombosis, and the history of like this miscarriages and PTT prolonged. In the box, they are not specifically talking about the PTT, but PTT is prolonged in APAS. Okay, okay. For diagnostic criteria for phospholipid antibody syndrome, one clinical, one lab criterion must be met. Venous thrombosis, arterial or venous. Pregnancy morbidity more than 3 consecutive unexplained fetal loss before 10 weeks. Uh, 3 or more than 3 consecutive unexplained fetal loss before 10 weeks. 1 or more unexplained fetal loss after 10 weeks. And 1 or more than 1 premature birth of normal neonate before 34 weeks due to preeclampsia, eclampsia, and placental insufficiency. Lab lupus anticoagulant, anticardial lipid antibody, anti-beta 2 glycoprotein 1 antibody. This patient has pulmonary emboli. This patient has pulmonary emboli due to right lower extremity DVT. Although risk of DVT is increased in several, although risk of DVT is increased in several inherited or acquired conditions. This patient's history of fetal losses and signs of SLE, myalgia, arthalgia, photosensitivity suggest antiphospholipid antibody syndrome. APS is characterized by following: venous, arterial, or small vessel thromboembolic disease and or pregnancy complications such as fetal loss. Lab evidence of antiphospholipid antibody in the serum, lupus anticoagulant, anticardiolipin, and anti-beta 2 glycoprotein 1 antibody. Patients with antiphospholipid antibody generally have prolonged PTT because antiphospholipid antibody bind with the phospholipid used in most testing assays and prevent them from inducing coagulation. These lab artifacts will not be fixed These lab artifacts will not be fixed by 1:1 mixing of 1:1 mixing with normal plasma, unlike coagulation factor deficiency. However, adding phospholipid to the testing assay will eventually overcome the presence will eventually will eventually will eventually overcome the presence of the inhibitor and normalize the PTT. This is an indirect way of identifying uh, lupus anticoagulant antibody. It is usually combined with other tests such as the diluted Russell Viper venom test and the kaolin clotting time for the diagnosis. Yes, factor V Leiden mutation is an altered form of coagulation factor V that renders it resistant to the anticoagulant effect of activated protein C. Risk of thromboembolism and fetal loss is significantly increased, but factor V Leiden is not linked by SLE and would not explain this patient's arthalgia, myalgia, and photosensitivity. Yes. Sorry. Preeclampsia, eclampsia. BP is with proteinuria, but there is no protein, only one plus. That not much. But 2 days of nausea, vomiting, back pain. It is ketones are high. Not ketorolac. Morphine patient control analgesia. Why? Preeclampsia, eclampsia. Is it max self, uh, or is it painkiller? Morphine. Sickle cell crisis, I think so. Sickle cell pain crisis. Okay, first box. Sickle cell disease and acute pain episodes. Sickle cell, there may be acute severe pain of in any location, elevated blood pressure, hemoglobin level is decreased, hemoglobin level is decreased, and there is hemolysis like increased bilirubin, increased LDH, and decreased heptoglobin. Increased bilirubin, increased LDH, and decreased heptoglobin. Reticulocyte count is increased. Platelet count is normal, and ALTST is also normal. So high reticulocyte count, and there is signs of hemolysis. There is signs of hemolysis. In here, total bilirubin is high. Okay. Okay. In preeclampsia with severe feature, there is persistent or severe headache, scotomata, with or without epigastric right upper quadrant pain. There is elevated BP. Hemoglobin level is normal or slightly increased. Hemolysis, non-reticulocyte count is normal. Platelet count is less than 1 lakh. And ASTLT is two time of upper limit of the normal. In HELP syndrome, epigastric right upper quadrant pain, nausea, vomiting, with or without headache, and there is elevated BP. Hemoglobin level is decreased. Bilirubin is increased, increased LDH and decreased heptoglobin. Reticulocyte count is high and platelet count is less than 1 lakh. And ASTLT is two times of upper limit of the normal. Okay, this patient with acute sickle cell disease and severe this patient with sickle cell disease and severe diffuse pain is likely to have acute pain episode. Pregnancy is associated with increased number of pain episodes, especially in the third trimester. This is because physiologic changes of pregnancy, increased metabolic demand, promote hemoglobin polymerization and sickle formation. In addition, maintenance medication hydroxyurea are often stopped by patients due to fear of fetal toxicity. This patient, these patients' severe nausea or vomiting, ketonuria, elevated amylase and transaminase level is likely triggering factor for these patients for this pain episode. The low hemoglobin, elevated reticulocyte count, and bilirubin provide evidence of chronic hemolysis is characterized by sickle cell disease. Hemolysis characteristics of sickle cell disease. Fetal heart rate deceleration are expected during a crisis due to decreased fetal oxygenation and perfusion, and resolve as the mother's condition stabilizes. Treatment of a vaso-occlusive pain episode in pregnant patient is similar to that in non-pregnant patient. IV hydration and aggressive pain control, morphine, patient control analgesia, and prompt and sufficient pain control with opioid is critical for relieving pain while its precipitation cause is treated. Yes. Magnesium sulfate is used in preeclampsia with severe features and helps syndrome hemolysis, elevated liver enzyme, low platelets. Although hemolysis is present, the transaminases are only mildly elevated and the platelet is normal, making health syndrome unlikely. Preeclampsia is marked by hypertension, blood pressure, pp 140 over 90 with proteinuria and the signs of end organ damage, elevated creatinine and transaminase level. This patient does not meet blood pressure and lab criteria for preeclampsia. Delivery is curative in HELLP syndrome. Delivery is curative in HELLP syndrome and preeclampsia. However, the associated blood loss can exacerbate an acute pain episode. What? There is jaundice, there is splenomegaly, left, right, anemia, the okay. You were thinking about, I think that you were thinking about autoimmune hemolytic anemia. Okay, the mother also, sorry. Family history includes similar yellowing of the skin after birth requiring phototherapy. Two, re two relatives, there are two relatives have splenectomy. Maybe sickle cell disease. Hereditary spherocytosis. Yes. In hereditary spherocytosis, MCHC is high and it is Coombs negative, isn't it? And reticulocyte count is high. Okay. So what's your catch in this question? Multiple, yes, multiple family members requiring splenectomy. This is the catch. Okay. Yes, you have told. Apart from this, no. Spleen. Like spleen is breaking the spherocyte and there is accumulation of the platelets within this or RBC within the spleen. Okay. So this patient splenomegaly and signs of hemolysis. This patient splenomegaly and signs of hemolysis anemia jaundice following an upper respiratory and this patient hemolysis splenomegaly and signs of hemolysis anemia jaundice following upper respiratory illness. This clinical feature along with a family history of multiple related recurrent splenectomy make hereditary spherocytosis is the most likely cause of hemolytic anemia. Hereditary spherocytosis is usually due to autosomal dominant defect in the red blood cell membrane protein spectrin ankyrin that results in sphere-shaped fragile RBC. Due to their shape and their abnormal RBC gets trapped and destroyed in the spleen. In all types of hemolytic anemia, the bone marrow produces increased reticulocyte count. The bone marrow produces increased reticulocytes in response to RBC breakdown. However, elevated MCHC due to membrane loss and RBC dehydration distinguishes hereditary spherocytosis from other forms of hemolysis. Other lab findings include low to normal MCV, negative direct Coombs test, spherocytocytes, or peripheral blood smear. Treatment involved supportive care, folic acid transfusion, and splenectomy for severe hemolysis. Yes, warm autoimmune hemolytic anemia can present with jaundice and splenomegaly but is characterized by positive direct Coombs test. Autoimmune hemolytic anemia may be triggered by upper respiratory illness but is unlikely to involve multiple family members because it is not inherited like hereditary spherocytosis. In addition, autoantibody production is rarely seen in newborn period. Low. Is it hydrospitalis? Oh, sorry. 9-year-old cannot be hydrospitalis. Low hematocrit, high reticulocyte count, hypotension. History of hematuria. L- like vaccination, is it, or periodic blood transfusion? Nanir, yes. Maybe like conjugated polysaccharide capsular vaccine, like because if somebody has infection and dies within several hours, like sickle cell, hemoglobin is low, probably, but they are talking about death prevented, or is it a periodic blood transfusion? I think that it is in between two. DNA. What is your diagnosis? Uh, Sorry. No. Hematuria abdominal. What reticulocyte count is higher in one of the splenic crisis, splenic sequestration crisis. I was right. And sickle. Just remember one thing: if sickle cell patient has any infection, it is written in the USML inner circle notes also. Like the patient who are sickle cell, sorry, the patient who have sickle cell disease, they are told to keep amoxicillin clavulanate like antibiotic. Whenever there is fever, straight start antibiotic without thinking anything, because if they do not start antibiotic, their spleen, uh, as they have splenic autoinfarction, the the capsulated organism actually burn their body. Like I remember in that way. So, patient with sickle cell anemia always, when there is infection, use antibiotic, because the encapsulated organism can infect you and can destroy and can cause you. Yeah. Okay. These patients' history and presentation are consistent with sickle cell anemia, complicated by acute bacterial infection. Clues to the diagnosis of the sickle cell anemia include his anemia and high reticulocyte count. So anemia and high reticulocyte count and previous admission of pain and hematuria. Patients with sickle cell anemia become functionally hyposplenic at an early age due to splenic autoinfarction. Thus, they are more susceptible than other patients to infection with encapsulated organisms such as Streptococcus pneumoniae, Haemophilus influenzae, Neisseria meningitis. Vaccination with conjugated Streptococcus pneumoniae vaccine decreases the incidence of invasive infection caused by this organism. Twice daily administration of prophylactic penicillin also given to children with sickle cell anemia until they reach 5 years of age. This boy actually 9 years, so this does not fit like twice daily prophylactic and penicillin, isn't it? Because he is 9 years old. Prophylactic penicillin for uh, as we are protecting them from any sort of infection up to fever. Yes. He has cancer. Chemotherapy. Is it duplex? Okay, upper extremity DVT. Okay, this patient's arm swelling, pain, and mild erythema. This patient's arm swelling, pain, and mild erythema develop in the setting of peripherally inserted central catheter PICC, raises strong suspicion for upper extremity DVT. All upper extremity central catheters, internal jugular, subclavian, are associated with increased risk of DVT due to endothelial trauma during insertion and improper positioning of the catheter tip. The risk of DVT is somewhat higher with PICC because they travel long distance through narrow peripheral veins, although occupying more than 50% of the total vein caliber. Hospitalized patients, particularly those with hypercoagulable state malignancy, are most likely to develop PICC related DVT. Upper extremity DVT is most common. Upper extremity DVT is most common within the 7 to 14 days of PICC insertion. The primary manifestation is arm or forearm swelling. Pain or mild erythema may also occur. In contrast to PICC infection, patients with DVT usually have a normal appearing catheter insertion size, no purulence. The diagnosis is made with compression or duplex ultrasonography, which visualizes the subclavian, axillary, and brachiocephalic vein. Although upper extremity DVT is associated with relatively low risk of pulmonary embolism, treatment with 3 months of anticoagulation is recommended. The PICC line can often remain in place. Yes, upper extremity DVT. Epidemiology central catheter or PICC line. Young athletic male spontaneous thoracic outlet obstruction. Manifestation unilateral arm or forearm edema, pain or heavy sensation, erythema, and dilated subcutaneous collateral veins. Doppler or duplex ultrasonography, 3 months of anticoagulation. Yes. Next. Just see the APTT. APTT is high, PT is normal. So never vitamin K. So no vitamin K. Vitamin K is PTT high. Okay, mixing study for prolonged PT or PTT. If there is elevated PT or PTT, 1:1 inhibitor mixing study. 1:1 inhibitor mixing study. If it corrects normal PTT, if it corrects normal PTT, that means there is factor deficiency. Evaluate for individual factors. If does not correct, then it is inhibitor, coagulation factor inhibitors. So inhibitors likely present like lupus and okay, these patients prolonged APTT. These patients prolonged APTT does not correct when mixing with normal plasma provides coagulation factor inhibitor. Normal plasma provides coagulation factors. Therefore, it corrects the prolonged PTT in the setting of coagulation factor deficiency, but fails to correct prolonged PTT in the setting of coagulation inhibitor. One of the most common coagulation inhibitor is lupus anticoagulant. Is a type Lupus anticoagulant is a type of antiphospholipid antibody. Lupus anticoagulant binds to the phospholipid used in most PTT tests and prevents them inducing coagulation, thereby prolonging PTT. This lab artifact is not improved with the addition of plasma mixing test but is resolved with the addition of phospholipids. Patients with uh, antiphospholipid antibodies may remain asymptomatic but are increased risk of antiphospholipid antibody syndrome, which is associated with thromboembolism and fetal loss. Most occur sporadically, and these patients' mother's DVTs are likely related to her orthopedic surgery rather than a clotting factor. Furthermore, the patient's thrombophilia is likely a byproduct of her infection rather than a platelet disorder. Okay, we can finish. We can finish 10, then we can stop. Yes, helmet cell. Okay, I'm okay. Ah, bilateral. Uh, is he a splenectomy? Mm, no. Okay, not helmet. Okay, Heinz ketchup. Heinz for G6PD. G6PD. Yes, yes. So it is not the answer. So it may be Howl Jolly. Okay, Howl Jolly bodies. Splenectomy in Howl Jolly body. Sorry, if there is functional hyposplenia or functional asplenia, there is Howl Jolly body. Mm, okay. There are four things present in splenectomy patient: thrombocytosis, lymphocytosis, Howell Jolly body, and another thing is okay, I don't remember. Okay, this patient with sickle cell disease has a typical vaso-occlusive praying crisis and a history of similar episodes. The repeated microinfarction from clumping of the sickle cell can destroy the splenic tissue, leading to microvascular beds that promote sickling. This chronic damage and autoinfarction of the spleen leads to functional asplenia by the age of 5 in patients with SCD because spleen is normally play an important role in the immunological spleen normally plays an important immunological role in the clearing of the bacteria from the blood. Functional hyposplenia, functional asplenia leads to susceptibility to infection, particularly from encapsulated bacteria. Strep pneumonia, Haemophilus influenza, Neisseria meningitis. A functional spleen removes the normal nuclear remnants and red blood cell or Howell-Jolly body. In patients with history of splenectomy and functional asplenia, as seen in this patient, Howell-Jolly body would be expected on peripheral blood smear. They appear as purple dots in the red blood cell. Purple dot in the red blood cell. Okay, okay, okay.